So thank you, Professor Saxena, for inviting me. It is my real pleasure and honor to be talking to you today across India about retinal imaging, wide field imaging, OCT, and OCT angiography. If you have any questions or thoughts, I think you will be able to contact the administrators directly, and we can talk about them at the end. So I work and come from the UK. This is a map of the UK on the top left. And actually the part of the UK I work in is in the southeast of the UK, just near London. So this little part, this square here is called Essex, and this is where I'm based. And the Anglia-Ruskin University is in the middle of the county, and Southend University is right in the south corner of Essex. So that's where I'm from. Now, if you try and look at KGMU to Southend Hospital, if you look on Google Maps, it says it takes 1 hour and 6 days. That's 1 day and 6 hours to travel. And actually now with the amazing ability of Zoom, here I am in Essex talking to you across India. And it's the pandemic has provided us with lots of new opportunities. It's also my real pleasure to be talking at this KGMU. My parents both qualified from KGMU in 1961 and 67. So it's a real honor to be speaking to you on behalf of KGMU. So I've been asked to talk about wide field imaging, spectral domain OCT, and OCT angiography. These are huge topics that I've spoken about individually, so combining them together will be quite superficial, and I hope if you've got any questions or any things you don't understand, you'll be free to ask me. Let's start with wide field imaging. So wide field imaging or ultra wide field imaging have been defined in 2019 by this paper by Chandra et al. In Ophthalmology Retina. Now, the posterior pole is the normal camera that many of us will have, and this covers just 50 degrees of the retina. And actually, this is a picture of the posterior pole in the bottom left. This is the standard camera, which just sees 50 degrees and just outside the arcades. Then we have wide field imaging, and this is images from beyond the arcades up until the posterior edge of the vortex ampulla, which is approximately 100 degrees of the retina. And this is defined as wide field imaging. And then we have ultra wide field imaging, which goes beyond 110 degrees, beyond the vortex vein ampulla to approximately the area of the pars plana. And currently this is only capable with the Optos camera. And then the ideal in the future is what they term pan-retinal imaging, which is up to 360 degrees. As yet, this is not possible. This is a picture of an ICG showing the three images. So this is the posterior pole in green. This is the optic disc. This is the 50 degrees of the posterior pole. Wide field imaging is up to the ampulla. These are the ampulla, which you will see here, all the vasculature coming out. And ultra wide field is beyond this area, so more than 100 to 110 degrees imaging. These are just to highlight where the vortex ampulla is on the ICG. So wide field imaging is essentially three machines are available: the Optos, which is in the top left, the Heidelberg in the top right, and the Claris, Zeiss Claris in the middle. The Optos takes images of up to 200 degrees with one photograph. The Zeiss Claris is about 133 degrees with one image, and the Heidelberg is about 102 degrees. These latter two machines can take wider pictures when you join the pictures together. I'll talk about a few conditions and the use of wide field imaging. Firstly, proliferative diabetic retinopathy. Here's a picture of a diabetic person, and you can see on the right eye has a few changes perhaps, and the left eye you can see some pre-retinal hemorrhage. So immediately when you see these pre-retinal hemorrhages, you may be suspicious that some proliferative retinopathy is happening. Standard 50-degree fluorescein angiography, well, in the left eye you can obviously see perhaps some new vessels, some leaking there with the fluorescein angiography. But the right eye, you may not see much with the standard 50 degrees. However, with wide field imaging, you can see immediately, even in the right eye, there's lots of areas that you may not have spotted with the clinical examination or even with the standard fluorescein angiography. You can see these areas here of leakage, indicative of proliferative retinopathy, even in the right eye. And the left eye, we are not surprised, to see lots of areas of neovascularization because we saw the pre-retinal hemorrhage in the left eye. Very useful, therefore, particularly with diabetic retinopathy, looking for peripheral changes. I'll move on to branched retinal vein occlusions. Here's a classic picture of a branched retinal vein occlusion. You can see the hemorrhages over the macula and the temporal part of the retina. Wide-field fluorescein angiography, however, can show you, although there's no neovascularization as yet, there's lots of areas here where there's poor blood flow or retinal ischemia. And this can then indicate that you might need to do pan-retina photocoagulation and maybe direct you as to where to apply the laser. And then just some more retinal vascular diseases, such as Coates disease, I'll describe here. This is a photograph of a right eye of a young man with Coates disease. And when you look close up, you can see here telangiectatic vessels and aneurysmal changes that are classical in Coates disease. And you can probably see those clinically. And when you look at the fluorescein angiogram, you may not be surprised to see that there's dropout or ischemia in this area. However, if you did normal fluorescein angiography, you may just focus on this area. But with one-shot wide-field angiography, and in this case, ultra-widefield, you can actually see here on the nasal side, there's also some changes that might direct you to apply more treatment in both areas. So this is very useful because you've seen here that there may be more than one area affected, which you may not have highlighted just with a normal fluorescein angiography. And wide-field imaging has now been demonstrated to have lots of roles in diabetic retinopathy, in telemedicine, which is very important, particularly now in the world of COVID, when we want to reduce the footfall of patients into the eye clinics. Telemedicine is very useful now and very important, and wide-field imaging has a real important role in diabetic retinopathy. It has a role in cancer management and cancer monitoring, and even in retinal detachments. This has a particularly useful role in documentation of retinal detachments and even diagnosis of retinal detachments sometimes. So wide-field imaging is really now becoming the standard of care in investigating retinal vascular disease, be it diabetic retinopathy, retinal vein occlusions, central retinal artery occlusions. And you can get very good images even through undilated pupils. With the Optos, you get what's known as ultra-wide field imaging, and with the other two, you get wide field imaging, although with montaging the pictures together, you can get ultra-wide view as well. Wide field imaging may reveal unexpected abnormalities. Suddenly, opticians in the UK are taking, some of them have wide field imaging and are diagnosing and highlighting conditions that they didn't necessarily see before. And for non-retinal specialists, it has a real useful role in spotting conditions, particularly out in the periphery. And as I showed with that example of BRVO, it can facilitate treatment planning such as laser. So wide field imaging has a real important role with current treatment. So I've briefly talked about wide field imaging now. And now I shall move on to OCT, in particular spectral domain OCT, and I'll talk about their mechanisms and their clinical use. So many of you will already be aware of OCT, but OCT is analogous to an ultrasound, apart from it uses light instead of sound. And it uses partial coherence interferometry to construct a retinal image. So what happens is you have a light source here on the left and a beam splitter. And you have your image that you want to take a picture of, and particularly the retina, and a reference mirror. So the light source sends the light out, it bounces off to the reference mirror and comes back, and also from your retina and comes back. And as the light returns back, the differences in the wavelengths will allow the machine to create an image of what is happening from the sample. And this is done by this detector here. It's complicated physics, and that's a very basic explanation of what happens. And what it does, as many of you will be aware of, it gives us a very good optical biopsy of the 12 layers of the retina. And I think this description of an optical biopsy is a very nice description and of what happens. And here's a histological picture, and you can see it really does, the image you get really does map out what you might see if you were to take a biopsy of the retina. Now, there's essentially two types of OCT, time domain OCT and Fourier domain OCT, which includes spectral domain and swept source OCT. Now I'm going to dwell on the latter two, Fourier domain OCT, which includes spectral domain and swept source OCT. You see the difference here. A spectral domain uses a light source, and swept source uses what's known as a tunable laser. And the spectral domain uses a spectrometer to analyze the images, whereas swept source OCT uses a photodiode. Now this is complicated, but it does give a slight difference in the images. So the spectral domain uses slightly shorter wavelengths of 840 nanometers, whereas swept source uses wavelengths of 1080 nanometers. Because of the slightly shorter wavelength, the spectral domain is better for more superficial layers, such as the retina, whereas the longer wavelength of the swept source allows you to go deeper into the choroid, or give you better images of the deeper structures. The spectral domain has slightly slower acquisition time, whereas a swept source has a faster acquisition time. The spectral domain gives you better contrast for the neuroretina, particularly the ganglion cell layer and the inner plexiform layer. And the swept source actually, as a consequence of its wavelength, gives you poor contrast for the neuroretina, but perhaps better contrast for the choroid. What is the use of spectral domain? Well, in retina, we use it all the time. Almost immediately with every examination, we will use an OCT. Macular degeneration is the obvious use. Here we have an image which is showing some subretinal fluid, which is this black area here. This is a pigment epithelial detachment, some intraretinal fluid, some hard hyperreflective material here, and here we have, or hard foci, and here we have this white area here is a subretinal hyperreflective material. Macular edema. Really, macular edema is now essentially diagnosed almost always with OCT, not rather than a clinical examination. And macular edema may be caused by retinal vein occlusions, for example, here, a central retinal vein occlusion. Diabetic macular edema, a huge problem, a growing problem across the world. Post-cataract surgery, we know that cystoid macular edema or ovine gas syndrome can be a real problem post-cataract surgery and can cause the vision to be poor. And really is diagnosed almost always now with OCT rather than clinical examination. Epiretinal membranes, and I shall come to this later on as well, and full thickness macular holes. Here you have a gap in the fovea showing the macular hole. This is a very busy slide, but this is cataract surgery saying post-operative analysis of the fovea. This is a meta-analysis of over 13 studies, over 650 eyes. And what it showed in what they described the risk factors for getting foveal thickness after cataract surgery was much more of a problem in Asian patients. Now, this will be very important in India, of course, but patients having cataract surgery who are Asian tend to have a significantly thicker fovea after cataract surgery. This may not be clinically evident, and an OCT done preoperatively and then postoperatively should probably be done now routinely where available, because it will be able to give us some idea as to post-cataract surgery thickening of the fovea, which may therefore give you some reason why the vision has not improved after cataract surgery as much as you might have hoped it to. And clinical examination may not be very accurate in diagnosing macular edema after cataract surgery. How about anterior segment OCT? It can be very useful in cataract surgery. Here we have a normal anterior segment OCT, and you can see the cornea here, the iris, and the normal lens. And here we have mature senile cataract, where the cataract is beginning to bulge forward. And you can see the difference to the normal OCT, normal lens there. And a hypermature cataract, you can start seeing liquefaction of the lens, particularly anteriorly. And here we have a posterior polar cataract, very useful. Here you can see the posterior capsule has probably become breached, and some of the lens material may be in contact with the vitreous. If you're planning to do cataract surgery, in such cases, the anterior segment OCT can be very useful in planning for your cataract surgery. But I'm going to talk a little bit now about surgical macular diseases and the role of OCT. And there's lots of uses, but I'll just briefly talk about three conditions: vitreomacular traction and epiretinal membrane, full thickness macular holes, and submacular hemorrhage. This is our day-to-day work really in surgical retina. So vitreomacular traction, this is something you probably will not diagnose clinically, and an OCT is critical for diagnosis and monitoring. And you can see progression here from the top left of the VMT, pulling on the fovea, and then maybe even causing more disruption to the foveal anatomy here. You can see here the fovea has a normal anatomy, and here the bottom right, it really is pulling on it. You can't diagnose this or monitor this clinically. You do need an OCT. And you can see this. Here we have huge distortion of the foveal anatomy caused by this vitreous pulling on it. And this person had good vision. And then actually you can monitor this. Their vision deteriorated here because you can see it pulled part of the fovea off. And then eventually, as that hyaloid or vitreous pulled off completely, their vision improved and their anatomy improved. It's very nice to watch the progression of vitreomacular traction, or VMT, with OCT. This is not possible with clinical examination, and really you must use OCT for this. And you can see here the vitreous is pulling on the fovea, disrupting the anatomy of the fovea and progression here. And this is a macular hole which is impending. We would not necessarily surgically treat this. You may watch this, but you can only watch this patient with repeated OCT scans. Vitreomacular traction may coexist with other diseases. Here we have dry macular degeneration. You can see here atrophy at the macula and pulling. You can see vitreomacular traction pulling on the fovea there. Wet macular degeneration can coexist in it, and even diabetic macular edema. So vitreomacular traction is something that actually is probably more common than we realize, and OCT is allowing us to see this more and more frequently. I mentioned epiretinal membrane. This is diagnosed really with a hyperreflective surface on the fovea. If you remember the normal image of the macula, here we have this hyperreflective band at the top left on top of the macula. And you get thickening of the macula, corrugations within it, and outer retinal changes. So here we have some outer retinal changes, and that will really determine the visual acuity, or the effect of the epiretinal membrane is really demonstrated by the outer retinal structures. And the outer retina is over here. I'm just going to show you quickly a case of a 64-year-old man who had very good vision, but he was very clear to me that he had described a triangle in his eye, or a sail. And the OCT here shows you some sort of flap on his fovea, actually leaving a shadow on the fovea. And he drew these pictures for me. He said, I can see this sail moving around when I move my eye. Now, he had good visual acuity, but he said this was really bothering him. And you can see here, this is his picture of a sail. And if you look at the picture of his fundus, this is the left eye. This is his optic disc. And you can see this here, sail, almost exactly like he describes, like he could draw it. And then, you know, he really wanted surgery for this, even though he had good visual acuity. We did a vitrectomy. And then we can see me peeling, this is my fellow, peeling the vitreomacular traction away from the fovea, off the macula. And you can see here preoperatively that flap leaving a shadow on the fovea, and when it's removed, that shadow is no longer there, and his symptoms were much improved. In fact, he was an artist, and he drew for me the pictures of him looking out his window. And this was day 1 after the surgery, because there was air in the eye. He could see the top of his window. By day 2, he could see more of his window. By day 3, he could eventually see his wife. And by 4, he could see most of the window. Anyway, that was vitreomacular traction. I'll talk about full thickness macular holes now. So macular holes are described as a full gap in the fovea. A full hole, it has to be a full gap. And you must be able to see down to the RPE. And the things that affect the surgical outcome are the ethnicity. So black patients have a poorer outcome. How long it's been there, the chronicity, and the size of the hole. Now, you can only really measure the size of the hole. You can only measure the size with an OCT. So for us, OCT of the macular hole is absolutely critical. Also, the shape of the hole. If you have a flat hole like this one on the right, the outcome is much worse than if you have a sort of pyramid-like hole on the left. And you might look for coexistence of epiretinal membrane on top of the macula, as you can see here with the red arrow. Surgery for full-thickness macular holes essentially involves peeling the internal limiting membrane. Just to remind you, the internal limiting membrane is about 2 to 5 micrometers in thickness, so about the thickness of a bacteria. And this is surgery for full-thickness macular hole, peeling the internal limiting membrane. So we stain the ILM with dual blue with a dye, and then that helps us see it, and then we can grab the internal limiting membrane and peel that away from the fovea. This is really the most standard surgical technique for full thickness macular holes. So we're performing a vitrectomy and then peeling the internal limiting membrane away from the macula and then putting air into the eye. You can see the bubbles of air coming into the eye, and that may be exchanged for gas. I'll briefly now mention a condition that I do think is a surgical retinal disease called submacular hemorrhage. This is an 88-year-old lady with wet macular degeneration. You can see the drusen around her macula and some atrophy and hemorrhage around the fovea. And the OCT is able to show us hemorrhage underneath the macula. What are the options? You can treat these people with anti-VEGF alone, or you can try and displace the hemorrhage just by putting gas into the eye, or you can do a vitrectomy and inject TPA, which is a thrombolytic drug, which is used often when people have strokes. It breaks up the blood, and you can put that directly under the macula. We published that actually the differences between these two techniques is very similar. There's no differences. So pneumatic involves just putting gas bubble into the vitreous cavity to displace the macula, and the vitrectomy surgery involves removing the vitreous and putting gas into the eye as well. So this is a lady this lady had a pneumatic displacement, and you can see the hemorrhage has displaced inferiorly. And then we injected here, you can see here the needle going under the macula and injecting TPA under the macula here. You may see a bleb of fluid appearing there. And you can maybe be able to see some fluid going underneath the macula there. There we are. And then we put gas into the eye. And then you can monitor these patients with OCT. So this is preoperatively with vision of 696. This is after injection of gas just into the eye, the vision improved. And then this is subsequently after vitrectomy. And you can see the macular anatomy has markedly improved. And this really, you must have OCTs to really follow this kind of patient. So that was surgical macular diseases and some cataracts. I'll talk briefly about glaucoma now and the use of OCT. So in glaucoma, we look at the inner layer, the retinal nerve fiber layer, the ganglion cell layer, and the inner plexiform layer to monitor the disease of glaucoma. Those are the layers that are affected by glaucoma. So the nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. These represent the inner retina. And we can segment all the 10 layers of the retina. And when you measure the ganglion cell layer and the inner plexiform layer separately, and you can see then, or you can monitor then how the glaucoma is affecting the patient. And if you look at glaucoma, here you have healthy controls, and at the end you have moderate to advanced glaucoma. The ganglion cell layer drops in thickness of the ganglion cell layer, the inner plexiform layer, and even the retinal nerve fiber layer. And the whole thing drops significantly as glaucoma gets worse. And therefore, using OCT, you can look at the temporal thinning where glaucoma predominantly occurs. I'll show you here. That is where glaucoma occurs, or the glaucoma initially occurs. The thinning of the inner retinal layers temporal to the fovea. So this is like a heat map. You can see this red is thick, and then it's becoming thinner here. This is the optic disc. This is the macula. It's becoming thinner temporal to the fovea, much like a shell. And this may indicate early disease of glaucoma, which you won't be able to necessarily spot by clinical examination or even visual field assessment. And here we have normal, and at the top you have normal images, very thick area around the fovea. And in glaucoma, you can see thinning, particularly temporally. And as the disease goes on, you get much worse thinning around the fovea. So this allows you to spot early disease and monitor glaucoma. Here we have early disease. This is the thickness of the inner retinal layer. And you can see here there's a drop here. So early disease may be spotted. Remember, glaucoma patients may lose 2 microns, just 2 microns of nerve fiber layer per year. And OCTs can therefore confirm progression over 18 months, which allows you to monitor I think, much more accurately glaucoma necessarily than just doing visual field assessment. So I've talked about OCT, how it can be used as an optical biopsy. It's critical for macular work, diabetes, macular degeneration, full thickness macular holes. I've talked about potentially its role in cataracts, and really it will become the use for monitoring glaucoma, probably much more accurately than visual field tests. So I've talked about wide field imaging, I've talked about OCT, and now I'm going to move on to OCT angiography. Really, OCT angiography came to us in 2014 in the seminal paper, which describes this as the next era of OCT technology. And this uses spectral domain or swift source OCT. So now I'm going to just quickly stop sharing my screen and move on to my keynote. Can you confirm, Professor Saxena, that you can see that screen?
Yes, we can see the screen.
Lovely.
Please proceed. Yeah.
Thank you very much. So with the spectral domain or swept source OCT, they are much faster than time domain OCT, and it allows you to take much more images. So here we have a picture of a left fundus, and we've drawn a square here of 3 by 3 millimeters. And the swept source and standard spectral domain OCT allow you to take many images. So up to 300 A scans per B scan line, so going horizontally. And then you can do that 300 times with 4 scans at each position. So you can take many images like this, going along this area, 4 scans at each point, 300 scans per B scan, and 300 times. So you're getting hundreds of thousands of images just from a 3 millimeter by 3 millimeter square. So essentially, this new OCT technology, allowing you to take many images very, very quickly, allows you to really understand what's happening with movement. So then when you've got those images, they do what's known as, the computer does something very clever called decorrelation algorithm, which basically looks for movement. So because you have lots of images, if there's any change between those images, that will be caused by movement. And what moves? The only thing that's moving is red blood cells. So because you have lots of images very, very quickly done, any change is caused by movement of red blood vessels. And then the machine can do something called deep correlation, which then allows you to map out blood vessels just by monitoring changes in the image, which is caused by movement. Now I'll give you an example here. So if you take a picture of my tap at home, hundreds of pictures, you will see there's slight changes in these images, and this is caused by movement of the water. So the same principle is done with OCT. Lots and lots of images, and any movement or any change in those images is caused by movement. And therefore the machine can therefore detect blood vessels, because that's where blood cells are moving, and that's the only thing that's moving in the macula. So the image flows to extrapolate to vessels. So you have lots of images, and then they squash those images into two-dimensional forms. It then it sets a threshold of what you will accept as movement. And then allows you to then differentiate between each layers of the retina. It's amazing, absolutely amazing. So essentially, OCT angiography looks at physiology. It looks at movement of blood vessels, which is physiology. It doesn't look at the anatomy only, it looks at the physiology because it's looking at the movement of blood vessels, which then the machine allows you to extrapolate to knowing where the blood vessels are. Now, is it better than fluorescein angiography? In many ways it is. So fluorescein angiography is invasive, whereas OCT-A is non-invasive. It allows you to look at microvasculature, and it lets you look at deeper layers than fluorescein will ever do. The cons are, well, fluorescein angiography shows you leakage, which is actually pathology. It actually shows you dynamic changes, which OCT angiography does not do. It does not show you leakage. And there are many, many artifacts in OCT angiography. But many people would suggest that leakage is actually a problem. Here you have a picture of fluorescein angiography in the bottom left, and the leakage actually masks many things underneath that, whereas the OCT-A on the right can show you problems deeper to where the fluid is, because it is not bothered, it is not affected by leakage. So it can really show you the micro vessels within the retina at each layer. Huge advantages over fluorescein angiography, and it's not invasive, it's just a picture. So I'll give you some examples. The problem with OCT-A is it gives us new vocabulary. When looking at macular degeneration, some people call the medusa, which is this image here on the right of a choroidal neovascular membrane. C fans, you can see this picture of the new vessels there, and anastomotic loops, and then dead inactive trees there. And the many new languages caused by OCT angiography has led to a huge number of publications on this. But I'll give you some examples. This is wet macular degeneration. This is a right eye with an optic disc, and you can see some hemorrhage at the macula. This is a 66-year-old lady who had visual acuity of 660 in this right eye. And this is an OCT which may show you some changes there. But OCT angiography allows you to scroll down. And you can see that the thing is scrolling down here on the right. And when you get to that white area, you start beginning to see there the choroidal neovascular membrane that's developed, which confirms that this is wet macular degeneration. I hope you saw that image of the new blood vessel coming. And this is again that wet, lacy, medusa-like picture of new membrane at the macula. How about this 91-year-old who had previous anti-VEGF treatment? Is this active? Well, you can scroll down here on the left, and as you scroll down, you can see there, that looks like a dead tree. So this is almost certainly inactive choroidal neovascular membrane. Now, there are many limitations to OCT angiography. The elderly you need very good image acquisition, and the elderly may have cataracts and difficult fixation, and that can lead to many problems in taking the images. And when you have lots of severe anatomical changes, such as in macular degeneration, the machinery can sometimes cause problems with deciding segmentation. But there's lots of rapid progress at the moment in OCT angiography. Here we have some segmentation error. So when the OCT angiography is done, it maps out every layer of the retina. And if there's anatomical problems, such as in macular degeneration, the machine may tell you inaccurately which part is which. And then it thinks that this part, for example, is the choroid, but actually it's still the retina. So you have to be able to be very wise when looking at the OCT angiography and make sure that you understand the different layers that might arise because of disease. And if the patient moves a lot, you get what's known as motion artifacts, which leads to a useless picture. And you can get decorrelation issues. So I mentioned decorrelation is how the machine interprets the movements. Now, If you set your threshold too high, you may miss disease. If you set it too low, you may get too much noise, like here on the left. And of course, things which might reflect movement, such as aneurysms, may cause the machine to think that there's disease when there isn't. I'm going to talk now about macular degeneration, and I'll just skip through some cases. So this is a lady with early macular degeneration. This is the structural OCT. And actually, as you do OCT angiography, you can confirm that there is no choroidal neovascular membrane developing. So this patient probably doesn't need any treatment. And OCT angiography allows that. This is a myopic young lady who'd had previous treatments in the past, and her vision had deteriorated to 660 over 8 weeks. There's not really much to see, as there often isn't in these myopic patients. But there's a little bit to see on the OCT. And as you scroll through the OCT angiography and go down, here you'll see on the left, there, you just see the choroidal neovascular membrane that's developing in her eye. So this is myopic choroidal neovascular membrane, really useful. Because often the OCT doesn't show things, normal OCT doesn't show issues in these myopic patients. And this is an inflammatory OCT, inflammatory CNV, which is difficult to spot, but as you go deeper, you may spot it. I'm going to skip through these images, poly-CNV, because I'm mindful of my time. This is someone with CSR, central serous retinopathy, who had it for 4 years. Her vision was 612, and this looks like classical CSR. However, there's this spot here, which as you do the OCT, and you can see scrolling through the structure of the retina, you can see now, just on that left, this patient has a choroidal neovascular membrane there, that white bit that's developed in association with her CSR. Dome-shaped macula. This is a relatively new diagnosis where the fovea is dome-shaped like this. And they often have what appears to be subretinal fluid, like this you may see, but if you do an OCT, you may be able to confirm, as you see on the left here, whether there is any membrane, and here there isn't. Although it might look like there's some fluid there, there is no membrane present. This is a 65-year-old myopic patient post-cataract surgery who has dome-shaped macula, like that, and there's some fluid here you can see just under the fovea. But as you do the OCT-A, actually you can see here, this lacy white area here, there is actually a choroidal neovascular membrane in association with this macula. This is a drusen. You can see here this bump at the fovea, and there's a black area above that drusen, which may make you think that there's fluid there. But as you do the OCT-A, you can see there is no choroidal neovascular membrane at the fovea. So this black area above the drusen is probably structural, not caused by a membrane. Briefly, retinal vein occlusions, you look for this, you can see very nicely demonstrating ischemia. So there's challenges with the thresholding of these images. You can get lots of false positives and false negatives. Because of the different algorithms between the machines, it can be sometimes difficult to compare studies. And we need longitudinal studies to confirm the reliability of different machines. So it's really useful in retinal vascular disease, very useful on AMD, very useful on non-AMD, but there is a learning curve. I'm going to stop my screen there and come back to this thing. So OCT-A really is useful for looking at the retina. I've talked about wide field imaging. We've talked about definitions. We've talked about its use in peripheral retinal changes. I've talked about spectral domain OCT, how it's very useful in the choroid and the vitreous, and looking at the structure and how we use it almost every day in retinal clinics. And I've given you a very quick run through OCT angiography. It's a very big topic that I hope I haven't confused you, because it is a difficult subject, and it's a relatively new tool. Peripheral vascular diseases in wide-field imaging, epiretinal membranes, macular degeneration, full-thickness holes, and their use in spectral domain OCT. And OCT angiography looks at the movement of blood vessels, so it visualizes motion and therefore gives us a picture of physiology, and really good for looking at the different layers of the retina. I'll acknowledge some of my images I received from colleagues of mine in London, Piers Keane. I used some of the images I was kindly given to by Heidelberg, and my previous trainer in Melbourne, Willie Campbell, gave me some of the images of wide-field imaging. So I hope I wasn't too long. I think I was just over 40 minutes. I'm very happy to answer any questions, or if you want to email me, this is my email at the bottom. Please feel free to email me. I like to make friends and collaborators across the world with anyone, so don't hesitate to email me, even if it's just to say hello.